this section we're going to go through some of the common bleeps that you can expect to receive when you're on ward cover shifts. So first of all, low BM is a relatively common one. There's a lot of patients who are diabetic and hence blood sugar abnormalities are things you will come across very commonly. So we've got to think about the causes and also the management. So with regards to causes, some of the most common causes are just poor oral intake whilst patients are in hospital, because if they're unwell, they're not keen on the hospital food, they may not be eating quite as much as they should. Inappropriate use of insulin or hypoglycemics like sulfonylureas can contribute to it as well. And finally, liver impairment is another thing to consider. So patients with chronic liver disease don't have quite as effective glycogen stores in their liver, and hence they may be more susceptible to developing hypoglycemia. The initial aspects of management involve establishing IV access and also assessing the patient's GCS. So if they are quite alert and able to swallow comfortably, then oral glucose or glucogel may be worth considering. If you think that their swallow is unsafe or they are drowsy, then 20% glucose, 100 ml, can help bring up the sugar levels. You may sometimes see 50 ml or 50% glucose being quoted elsewhere. In my experience, I've not really seen it ever being used because 50% glucose is pretty viscous and may only be appropriate to administer through central lines. So 100 ml of 20% glucose is an effective option. IM glucagon 1 mg can also help bring up the glucose levels. So a couple of other things to consider is that once a patient has had a hypo, you should monitor their glucose quite regularly for the next few hours just to make sure that it doesn't go low again. You'd also want to have a look at the regular insulin prescription that's been issued and compare that with the BM chart just to see whether there seem to be any consistent times in the day when patients are becoming hypoglycemic, because it may be the case that they have perhaps too high a dose in the evening and hence they tend to wake up in the morning quite hypoglycemic, in which case you might want to adjust the regular insulin. A food chart is also useful because that may be able to hint at poor oral intake being the cause of low BM. High BM, on the other hand, causes include missed insulin, having eaten quite recently, being just acutely unwell, and also being treated with steroids for whatever reason. And in terms of assessment, you want to check the ketones because patients may develop DKA. And you want to do a VBG as well just to check if the patient is becoming acidotic. You want to assess their fluid balance because high BMs can lead to quite profound dehydration. And you want to check the drug chart to see what medications the patient is already on. So one point I'd like to make with regards to BMs and ketones is that patients who are on SGLT2 inhibitors like empagliflozin, they can develop a euglycemic ketoacidosis. So they can develop a ketosis without the BMs being particularly high just because of the way that the drug works. So that's another thing to bear in mind. So when patients have very high BMs, there are two main emergency diagnoses to consider. So one of them is DKA, which is characterized by high glucose, ketosis, and acidosis, and that's generally managed with IV fluids and a fixed rate insulin infusion. HHS, on the other hand, is characterized by high glucose, no significant ketonemia, very bad dehydration, and a high serum osmolality, which can be inferred by using the equation shown there. So if it's over 320, that tends to be in keeping with the diagnosis of HHS. So as for the management, I'm going to focus on just high BM management without any serious complications like DKA or HHS, because those two conditions are managed separately and is covered elsewhere in this course. But with just an isolated high BM without any of the complications like DKA or HHS, you would consider giving IV fluids if the patient appears dehydrated. You may, under certain circumstances, consider giving a stat dose of short-acting insulin like Actrapid or Novorapid, though sometimes you do hear that that's not necessarily good practice to do so. The other thing to consider is having a look at the insulin prescription and the BM charts. And like I mentioned earlier, if you see that there's any particular times that they tend to be getting very hypoglycemic, it may be the case that you just need to adjust some of their insulin doses. And again, patients should have more frequent BM monitoring in the hours after you've assessed and managed a patient with high BMs. Right, pain is another thing that you'll need to manage quite often. So you'll get bleeps from various parts of the ward saying that a patient is complaining of pain somewhere, and you need to manage it. So of course, if the patient has pain that's new, or there's no real clear cause for the pain, then you need to further assess that and investigate that appropriately. So for example, if someone has new chest pain, you need to assess that as you would any patient with chest pain. This slide is mainly focusing just on the WHO pain ladder and the medications that you may consider in patients who have pain for some known defined reason. So for example, let's say they're a post-op patient having had a appendicectomy or whatever, and they're struggling with the pain, then these are the options to consider. So at the bottom of this ladder is paracetamol. It's very effective at managing mild pain, very readily available. A possible caution is if someone has very severe liver impairment, though to be honest, much of the time giving a lower dose of paracetamol is still safe in most cases of patients with liver impairment. NSAIDs like ibuprofen can also be quite effective, especially for musculoskeletal type pain. It should generally be avoided in patients who have quite significant renal impairments or if they have any history of peptic ulcer disease. And then you move on to the opioids. So the opioids are very effective at managing most kinds of pain, but you should be wary of using them in elderly patients because they can become confused, drowsy, and constipated. In patients with an already reduced GCS for whatever reason, perhaps they've got a hypoactive delirium, then opioids can make that worse. And many opioids are also contraindicated in patients with impaired renal function, but there are alternative opioids which would be safe to give in those circumstances. So just focusing on opioids, it has its own sort of ladder within the domain of opioids. So at the weaker end of the spectrum, we have codeine and dihydrocodeine. Moderate opioids include tramadol, and stronger opioids include morphine, oxycodone, buprenorphine, and fentanyl. So one thing that you may be asked to do on occasion is switching between different types of opioids. So for example, let's say a patient is usually on morphine, but then they develop quite a bad AKI and hence they need to be switched onto oxycodone. So there's a few rules you need to learn in terms of doing these transitions. So we're going to use oral morphine as our sort of base in terms of thinking about doses. So first and foremost, if you're converting from oral to IV morphine, let's say the patient is being kept Nil-by-Mouth or their swallow is unsafe, then you just divide the usual oral morphine dose by 2. So let's say the patient has previously had PRN 5 milligrams of oral morph to manage pain. You would change that to PRN IV morphine 2.5 milligrams. So morphine can then be thought of in immediate release and modified release formulations in terms of the oral forms. So the immediate release forms tend to be given maximum 4 hourly, and the most common example that you'll see is Oromorph, whereas modified release formulations can be 12 hourly or 24 hourly, and there's a bunch of examples. So much of the time we do use generic drug names in medicine in the UK, however there are a few exceptions. So things like insulins, opioids, and antiepileptics, you tend to use the brand names more frequently. So examples of modified release morphine include MST Continuous, Zomorph, and Morphgesic SR. Sometimes, especially with surgical patients, you may find that they're using the PRN morphine quite frequently, and hence it would make more sense to give them modified release morphine to try and sort of even out the management of their pain. So rather than them needing to be in really bad pain to ask for the pain relief, you can switch the immediate release morphine to modified release preparations to give them a better sort of baseline level of pain control. So let's say a patient has had some sort of operation and they're prescribed PRN immediate release morphine, but they're using it quite frequently. The way that you do the change is that you look at how much morphine they are using in a day, and then you just give that same dose as a 25 hourly preparation, or you divide that by 2 and give it as 12 hourly preparations of modified release morphine. So that's simple enough. And we will also talk about breakthrough pain in a moment. So in patients with renal impairment, you may switch morphine to oxycodone. So oxycodone is also available in immediate and modified release formats, and I've got the brand names available there. There's various opioid conversion tables available on the BNF and Medicines Complete where you can see the correlation between oral morphine and oral oxycodone, for example. So here we have a diagram showing pain as the blue line and pain control as the green line. So ideally, you want to maintain the pain relief such that it's able to sort of overcome the pain throughout the course of the day. And what I've shown here is a 12-hourly modified release preparation of morphine or whatever it may be, showing how it's managing the pain. So sometimes patients may have breakthrough pain, which is when the pain exceeds the level of pain control that's offered. And in those circumstances, you want to have breakthrough analgesia available to be able to manage those episodes. So this could be oral morphine or oral oxycodone, so it's immediate release formulations that patients can ask for when the pain gets really bad and their modified release pain control isn't really cutting it. So that's normally prescribed as a 10th or a 6th of the total daily dose of the modified release preparations that's being used. So let's say if the patient is on 30 milligrams BD of modified release morphine, then the oral breakthrough dose will probably be about 5 to 10 milligrams of immediate release morphine. So I mentioned that Medicines Complete and the BNF have these opioid conversion tables, but I thought I'd give you just a couple of examples of these conversions, just in case it's useful in the future. So the main opioids that you likely come across in addition to morphine are oxycodone, tramadol, and codeine. So 10 milligrams of oral morphine corresponds with 5 milligrams of oral oxycodone, or 2.5 milligrams of parenteral oxycodone. So essentially oxycodone is twice as potent as morphine. 10 milligrams of oral morphine is equivalent to 100 milligrams of oral tramadol, and that's also equivalent to 100 milligrams of IV tramadol. 10 milligrams of oral morphine is also equivalent to 100 milligrams of oral codeine, and codeine doesn't have an IV option. Nausea and vomiting is another very common bleep that you'll be asked about. So if someone is mentioned to be suffering from nausea or has been vomiting, do consider the potential causes. So it may potentially be drug-induced, so especially patients who are on a lot of opioids. It could be due to some sort of infection like gastroenteritis. It could be just due to intense pain. And the other thing to consider, very important thing to consider, is if there is any obstruction to the GI tract. So like a small bowel obstruction, for example. The main antiemetics that tend to be used in hospital, especially when you're on board cover, are listed along the left there. And each of them tends to have some sort of caution that you should keep at the back of your mind when you are prescribing it. So ondansetron tends to be a pretty safe option that's used quite often in hospital medicine. The only caution is that it can cause worsening constipation. Cyclizine is also very effective, but if it's given intravenously, it can cause a bit of a rush, and there have been plenty of cases of patients becoming addicted to IV cyclizine and demonstrating some drug-seeking behavior. Metoclopramide is a prokinetic. It can cause these sort of dystonic reactions like an oculogyric crisis, especially in younger people. And you've also got to be wary of using metoclopramide in patients with a mechanical bowel obstruction, because given that it's a prokinetic, if there is a mechanical bowel obstruction, it can actually make the nausea worse by essentially squeezing your GI tract against this obstruction. Prochlorperazine is another option that's used perhaps less frequently than the other options here, and one caution is that it can cause confusion in the elderly. Sometimes you may find that patients are being kept Nil-by-Mouth, and the context includes some concerns about their swallow, so perhaps they may have aspirated, they may be awaiting surgery the following day, or they may be awaiting an endoscopy. In these cases, you obviously need to make sure the patient remains hydrated, so giving them some IV fluids 8 to 12 hourly is very important. So options include pretty much any type of fluid, really. It's based on perhaps the patient's electrolytes and also whatever's available on the ward. There are a few special considerations in some patients who are being kept Nil-by-Mouth. So if they are diabetic, generally speaking, long-acting insulin should be continued because patients need to maintain a little bit of sort of baseline insulin in order to prevent them from becoming ketotic. You may also switch them onto a variable rate insulin infusion just to make sure that you can sort of almost take over the role of a pancreas and just adjust their insulin based on their requirements. You also want to check the fluid prescribing guidelines as well, because when patients are on a variable rate insulin infusion, there tend to be specific fluids that they tend to be co-prescribed with. So for example, at one of the trusts that I've worked at, variable rate insulin infusions are given along with a 0.18% saline and 4% dextrose infusion. But you've also got to think about critical drugs as well. So most medications can probably be omitted for a few days without much trouble. The only exceptions really are Parkinson's medications, anticonvulsants, antiretrovirals, and long-term steroids. So you need to consider alternative ways of giving these medications. So maybe potentially by inserting an NG tube, giving a patch or IV formulations as well. Right, fever. So you'll quite often get a call from nurses on the ward saying a patient has spiked a fever. So first of all, from a symptomatic perspective, paracetamol is a very effective way of actually getting control of a fever. And then you've got to consider a few things. So is there systemic upset? Is this patient septic, or have they just got an isolated fever? Sometimes an isolated fever may be of no great consequence whatsoever and is just a one-off, which doesn't happen again. If they do seem to be having symptoms of an infection, you need to think about where is the source likely to be, especially in hospital inpatients. Hospital-acquired pneumonias, UTIs, skin infections are pretty common, so you need to try and figure out where is the infection coming from. Then you've got to ask, like, is this infection known about? Is this something new, or has this patient been treated for this infection thus far? And the final consideration is in surgical patients. So they have slightly different causes for infections. So they may have surgical site infections, they could have an anastomotic leaks which can cause fevers, and they can also develop collections in their abdomen or wherever they've had surgery, which can then cause fevers and systemic upset. So these are the questions that you should be asking yourself when you get bleeped about a patient who has spiked a temperature. As for the investigations, you want to figure out where is this fever coming from. So urinalysis, a chest x-ray, stool sample if they've got some diarrhea, blood cultures as well is very important, and routine bloods just to demonstrate evidence of raised inflammatory markers, which are also supporting your diagnosis of some sort of infection somewhere. As for the management, it's primarily following the sepsis 6 and in particular prescribing some empirical antibiotics. So quite often hospital guidelines will have systems-based recommendations in terms of the antibiotics. So it may say urine infections treat with this, chest infections treat with this, and it may also say that there's options for empirical antibiotic treatment in fever of unknown origin. So it's worth checking the guidelines, the local guidelines, to figure out which antibiotics are most effective.